respiratory system diseases हैन अब अलिकति तिमीलाई अलिकति यो चाहिँ गाह्रो हुन्छ हैन किनभने यु हेभ नट गन थ्रु यो क्लिनिकल पोस्टिङ्स ड्युरिङ यो फर्स्ट इयर एन्ड सेकेन्ड इयरमा पाएन होला हैन त्यो हुनाले अब अलिकति टर्म्सहरू चाहिँ के यु हेभ टु बी के स्लाइटली भिजिलेन्ट अनि त्यो चाहिँ अब प्र्याक्टिकलमा हामीले लिइ नै हाल्छौँ तर अब आई विल ट्राई टु कभर अप होइन यो के व्हाट आर द टर्मिनोलोजिस अन दिस लेक्चर यदि टाइम सक्यो भने विल रिजोइन है सो इट विल नट बी फिनिस इन 14 मिनट्स के 40 मिनट्समा फिनिस हुँदैन रिजोइन विथ द सेम लिङ्क एडमिट गर्नु today we are going to for the approach of cough and breathlessness. So whenever the patient of respiratory complaints comes to you, the main cardinal features or cardinal symptoms the patient will present with certain complaints. Okay, so these are the one of the two important complaints with which the patient will present to you, and the another is the chest pain and another is a wheezing. So chest pain will be dealt by Dr. Ramesh on the next lecture. So it's mainly we are concentrating more on the cough and breathlessness, the two complaints. Okay, then so let's start with the clinical scenario. Clinical scenario. So this is a 69 years old male presented with a complaint of cough for 2 weeks and shortness of breath for 3 days. And patient also has a history of cough which was productive. Okay, so so these are the terms that you should be more cumbersome with. Okay, so productive sputum is mainly a patient is expectorating the sputum is there, and with which is always sputum scanty in amount, not blood mix and increase in night. Okay, in the night time. And then the patient also has a history of shortness of breath, which was acute on onset, gradually progressive, which is aggravated by activity and relieved by rest. Okay, so patient is mainly having a cough and the shortness of breath for certain duration. The patient presents to you. And then on examination, on chest examination, there is a bilateral, so normal vesicular breath sound. The vesicular breath sound is a normal breath sound. Okay, so it's a normal breath sound in which the inspiration is longer than the expiration, and there is no gap, and expiration is 1/3 of the inspiration. So that's a normal auscultative findings that you are going to hear. And the wheeze and the creps are the added sounds. Okay, so these are the added sounds, so that will is present on this patient. And then the other systemic examination were within the normal limits. During the diagnostic workup, routine investigation along with spin profile was done, and patient was on inhaler for the hypertension. So it was changed to losartan because we are thinking of AC inhibitor induced cough on this patient because of the inhaler. Okay, so that's why we changed into ARB in this group of patient. Then at the time of the presentation, the pulse is 98 per minute, which was regular, and blood pressure is 130 by 80 mmHg, and respiratory rate is 28 per minute, and the saturation is 93% with 1 liter of oxygen in this patient. Then the patient has gone into, we have done the high resolution CT scan on this patient. So it shows small tiny nodular opacities was present, and the left upper lobe and basal segment of the right upper lobe is mainly we are thinking of the infective origin. Okay, so, and then the calcified granuloma, and then we went for the spirometry to see whether there is any airway disease in this patient or not, and then it revealed the obstetric pattern in the spirometry, that is FEV1 by FVC is less than 70. Okay, so you might have known this in the physiology class of the spirometry. To say this is the obstruction, then we'll look for the ratio of force expiratory volume divided by force vital capacity, and that is, if it is less than 70%, then we can think this is the patient is having a obstructive disease. And then later the sputum AFP came out to be AFP 3 plus on this patient in the both sample, and the final diagnosis was made as a COPD, predominantly chronic bronchitis with pulmonary tuberculosis. Okay, so this is how the patient will present to you. So this is how you will approach the both breathlessness and then the by doing the certain investigation. So now with this clinical scenario, we'll mainly first cover up with the cough and then followed by the breathlessness. Okay, so what is cough? Cough is a vital protective reflex preventing the aspiration and enhancing the airway clearance. Okay, and however, the pathologically excessive and protracted cough is a common and disabling complaint affecting perhaps 5% to 10% of the adults. Okay, excessive cough can be complicated by emesis. Sometimes the patient can have a post-tussive syncope. Okay, so after vigorous coughing, the patient can have a fainting attack, that is known as syncope, or known as a post-tussive syncope, muscular pain, or rib fracture. Even the rib fracture can be there. Okay, so if the excessive coughing, and aggravation of low back pain, abdominal and inguinal hernia. Okay, so the one of the risk factor of the inguinal hernia is uncontrolled cough. Okay, so if the patient has a persistent cough, then the inguinal hernia. So whenever the surgeon is going to repair the inguinal hernia, they always send to us to control the cough. If the patient has COPD, then give the treatment of COPD and control it. Otherwise, there will be always a failure of the hernia repair. And the patient can also have a urinary incontinence, and also impediment to the social interaction. Okay, so when the patient have a continuous cough, and it is mainly a one of the debilitating complaint the patient can present to you. And then, so based on duration, the cough can be divided into acute cough, which is less than 3 weeks, and subacute cough, which is 3 to 8 weeks, and the chronic cough more than 8 weeks. So why this duration is important? Because we have to think about certain conditions. If the patient presents with a longer duration of the cough, and if the patient presents with a shorter duration of cough, then we have to think about the certain other differential diagnosis. Okay, so some terminology you should know is what is a refractory chronic cough that persists despite guideline-based treatment for the chronic cough is the refractory chronic cough. And then unexplained chronic cough is a cough with no clear identifiable cause. Okay, so if you are not finding out any identifiable cause after a full diagnostic workup for the chronic cough, then it is known as a unexplained chronic cough. Okay, so these are the certain terminologies you should know. Then coming to the causes, so this is the box which is from your textbook, Davidson. Okay, so your textbook will be the Davidson, so you should always stick out to that. So you start reading the Davidson. So this is the box from the Davidson. So always think about the anatomy. Okay, so your anatomy, your physiology is always a pillar to your clinical science. Okay, so if you are good on this basic science, then it will be very easy for you to to know all these things. Okay, and that's why yesterday in the orientation we have said that is a pillar. Okay, so it's a basic science. So coming to the anatomy, so start from the upper respiratory tract. Okay, so from pharynx, from larynx, and itself from the sinus itself. Okay, so sinus itself, so that will be causing a cough. Okay, so if there is a pharynx or even a sinus or sinusitis, the patient can have a post-nasal drip. Okay, so the secretion not only come from the anterior nares, it can go back to the posterior nares, and it will trickle down into the pharynx and causing the irritation of the pharynx, causing the cough. Okay, so it's mainly a history of chronic rhinitis, rhinosinusitis. The patient will have a this, and the patient will have a cough. Okay? And then in the larynx, so another is a laryngitis, tumor, whooping cough. Okay, and the croup. Okay, so croup, any viral croup that can be. So patient can have a voice or swelling can be altered voice will be there, harsh or painful cough will be there, and the paroxysms of cough, it comes on the paroxysmal attacks, okay, like that, and often associated with the stridor. So stridor is the another sound which is mainly inspiratory. Okay, so in this the stridor will be there. So stridor is mainly just like a wheezing sound which you can hear in the chest, whereas the stridor you can be audible outside. Okay, so the stridor is present, so it's mainly always think about the upper airways, and mainly is a laryngitis or involvement of larynx or vocal cord and all these things. Okay, and that is the another one is a medical emergency if the patient has a stridor. And then the trachea can be tracheitis. So the patient can have a raw retroesternal chest pain with cough. That is mainly a trachea. Okay, so retroesternal chest pain, and the patient has a cough. Then we can think about the tracheitis. The bronchi. So bronchi it can be a acute bronchitis. Okay, so acute bronchitis. So everyone must have been suffer from the acute bronchitis. If the patient has if you have a viral infection, then always if you have a hacking cough and the portic cough and then the wheezing, then you can think always of the acute bronchitis. And if the is chronic, then it's a COPD. The spectrum of COPD is emphysema and the chronic bronchitis. So we'll deal with this in the airway disease lecture. Okay, so a patient can have a dry or portic cough worse in the mornings, and the another is asthma. Even the patient has a usually dry cough, and it is mainly worse at the night. And eosinophilic bronchitis is the another one. Okay, so you have to think about it. The patient has a eosinophilia is there, and it is not like a asthma. Okay, so it can be only a eosinophilic bronchitis. The feature similar to the asthma, but there will be always a airway hyperreactivity is absent on in this in the eosinophilic bronchitis. And another cause of the chronic cough is the lung cancer. It is a persistent, and then it might be associated with hemoptysis. Okay, so there will be a blood thin sputum can be present. And then coming to the lung parenchyma, it can be a tuberculosis, pneumonia. Okay, so in tuberculosis you can get the parotid cough, and it is one of the cause of the chronic cough. Whenever in our scenario, in our context, in our reason, if the patient presents with a chronic cough with a history of more than 3 weeks, or then always we have to suspect it might be a tuberculosis, and we have to rule it out the tuberculosis on every patient. Okay, and then in the pneumonia, dry initially and productive later, and the bronchiectasis is a productive cough which changes in posture induced sputum production. Okay, so in the bronchiectasis there is always a postural change of the sputum production. Okay, so because the bronchiectasis there might be involvement of certain lobes. Okay, so and then the point of secretion is there, and whenever it changes on the dependent part, then the patient will have a expectoration of the cough on that position. Okay, so there's mainly a postural variation in case of bronchiectasis. And the another is a pulmonary edema. Okay, so pulmonary edema is mainly the often at the night when the patient goes to sleep. Okay, so there will be might be a pulmonary congestion and maybe a productive, which is mainly a classical sputum that you are going to get is a pink and frothy sputum in the case of pulmonary edema. And then the interstitial fibrosis is mainly now in the COVID era. So we are going to get a lot of patients of the interstitial fibrosis after post-COVID. Okay, and also there is a interstitial lung disease. So that's a big topic that will come on the lectures. Okay, on the coming days, is the patient will have a dry cough, and mainly is a persistent chronic dry cough, and it is very distressing, and the patient will have a chronic exertional dyspnea on this interstitial fibrosis. And then the drug side effect, the patient, just like in our patient, we change into AC inhibitors to the ARVs. Okay, so ARVs, so patient can have a dry cough in that because of the AC inhibitors. So always ask in the history whether the patient is taking AC inhibitors or not, if the patient presents with dry cough. And then the aspiration, as another is important, is a gastroesophageal reflux disease. So if the patient has a GRD, and the history of acid reflux, heartburn, hiatus hernia, and the obesity will be all these are the risk factors. If the patient has hiatus hernia, obesity, all these will increase the GRD. Okay, so gastroesophageal reflux. So when the gas comes and irritates your throat, and the gas which also been inhaled, so that causes the as acts as an irritant and causing the cough. Okay, so always we have to ask about the history of acid reflux in the patient presents with cough. So with this background, completing the causes. So causes of mainly a chronic cough. If the patient presents with chronic cough, always think about COPD, cough and asthma, non-asthmatic eosinophilic bronchitis, reflux cough like GRD, and the another is a upper airway cough syndrome, that is mainly a postnasal drip syndrome. Okay, so always ask about the history of sinusitis, rhinitis like sneezing. Okay, so these all will give you the clue, and the pulmonary tuberculosis and the bronchiectasis. So these are the common causes, and the other causes, uncommon causes, are medications, interstitial lung disease. So now it listed in the uncommon causes interstitial lung disease. Now because of the post-COVID, always think about the interstitial lung disease or post-COVID fibrosis. Okay, so these are the important things. Then the lung cancer and the post-bronchitic cough, and then the congestive heart failure. Okay, so the patient has a persistent left ventricular heart failure. The patient have a persistent lung pulmonary congestion because of the backflow of the blood towards the pulmonary circulation, and then the extravasation of that fluid in the alveoli, causing the cough. Okay, so there's mainly a pulmonary edema is going on in the patient with the congestive heart failure. In the patient of just like a left ventricular heart disease, is a left ventricular diastolic, systolic dysfunction. Even in the case of mitral stenosis, mitral regurgitation, aortic regurgitation, all these will lead into a heart failure. Okay, so it's mainly a biventricular heart failure. Mainly the patient will have a cough, mainly in case of left ventricular heart failure. Okay, so left ventricular heart failure, and then the another is a psychogenic causes are there, in which the patient will have a chronic cough. So with this background, so how do we approach? So mainly is mainly considered into history, physical examination, and the investigations that we are mainly concerned. So what are the histories that you are going to look in the patient particulars, that you are going to ask about the age has certain important thing that will give us the guide. A big prevalence of chronic cough in the sixth decade of life. If it is a chronic cough, asthma and upper airway syndromes are more common in the young adults. Okay, and COPD, reflux cough, lung malignancy are more common in the older age. And then the sexual distribution is more common in the females. Okay, because of the hormonal factors. And then the occupational lung disease. Okay, so the occupation is very important in the case of respiratory history, so always ask about the occupation, so you should not miss the occupation. Okay, so occupational lung disease, so either it can be a byssinosis, or it can be a variolosis. Okay, it might be a basisosis, so you might have known these terms, or even in case of pneumoconiosis, farmer lungs. Okay, so these are the sugarcane industries, the patient working in sugarcane field, if the patient is working on the cotton wool fields. So all these causes the certain occupational lung disease, or even the silicosis. Okay, so if the patient is working on cement factories, and the person is working on the roadside to break that stones. Okay, so small stones. So these all are leading to the silicosis. Okay, so silicosis is the another thing that we should not miss in our scenario. Then the sorry. So chronic cough. So this is mainly a definition that the slide has come on the second. Okay, is often described as cough because of the hypersensitivity syndrome. Is triggered by the exposure to the low level of thermal, chemical, or mechanical stimulation. Okay, so that's mainly a important thing that we have to think about. So let's, and then the coming to the history of present illness. So present illness, and so present illness. So characterization of cough is very important. So duration of the cough is mainly important, as you know, whether it's acute, chronic, or it can be a subacute, and the circumstances that surrounded the onset of cough. Okay, so that's mainly important for the chronic cough. And the productive and the non-productive cough is the another thing that you have to ask, whether you are dealing with a patient with a dry cough. So if it's a dry cough, then there are certain causes, and if it's a productive, then we have to think about the certain causes. Okay, so productive, why is productive, is mainly when your airways, as you know from your anatomy or histology background. So the productive cough is mainly produce the sputum production, from which cells the sputum will be produced. Which cell is producing the sputum in the airways? Anyone can
Goblet
answer?
cell.
Goblet cells. So where is the lining from the lining of the goblet cell starts from? It is from trachea, larynx, or bronchus.
trachea.
So it is from bronchus. Okay, so it is from bronchus. So if the patient has a priority cough, then you should think about. So it might be dealing with a condition. It is below the trachea. Okay, so it's mainly because of from there, unless and until it is the postnasal drip. Okay, so postnasal drip. So mostly the production of the sputum, if the patient is producing the mucus, then you can think. So it is coming from the lower airways, so it's mainly from down below the trachea. Okay, so it might be from bronchus, or it might be from the parenchyma alveoli. Okay, from that region. So the patient will not produce the cough sputum production from the disease from the interstitium, because there is no any connection with the airways. And then if the patient will have also any disease from the pleura, the patient will have only a non-priority or dry cough. Okay, so if the patient is producing the sputum, then you should think about there might be a something which is being dealt with the bronchus and the alveoli. Okay, so there's mainly a thing that we have to think about. Then coming to the time of the occurrence of during the day. Okay, so at what time the cough is going to happen. So if it is on the early morning, so just like in the asthma, or why there is a early morning cough in the asthma. So what happens? Anyone can answer, please. So while in the daytime, okay, so in the daytime, if there is something is pent up, then we will tend to clear it out. But during the night, what happens? Your respiratory center is going to being depressed, okay, and so if in the case of asthma, the secretion is going to pent up, and then it will cause the obstruction of the airways. So as the airways is always a hyperactive in case of bronchial asthma, so in the early morning, so there will be always a bronchoconstriction, and if there is a pent up secretion is there, so the airways is get obstructed. So that's why the patient will wake up to clear out the sputum. Okay, so that's why there's always in the early morning there is a increased attack of the bronchial asthma. Okay, so that's the main background. And then the pattern of the coughing is example occurring in paroxysmus. Okay, so paroxysm, then we have to think about a certain condition and associated features with cough, aggravating and relieving factors, and the drug history is important that we have to characterize while taking the history. So if it's a priority cough, then we have to think about conditions like bronchiectasis, chronic bronchitis, eosinophilic bronchitis, and pulmonary tuberculosis. Okay, pulmonary tuberculosis, and even case of pneumonias. Okay, so the pulmonary tuberculosis itself causes a pneumonia. And then the dry cough, you can think about the interstitial lung disease, pleural disease, or mediastinal disease, because it has no connection with the airways. Okay, so until and unless the pleura will connect to the airways because of the bronchopleural fistula. Okay, so if there is a fistula only, then the patient will have a production of the sputum. Otherwise, there will be always a dry cough. So interstitial lung disease, pleural disease, and the mediastinal disease. Then if it is prolonged and paroxysmal cough, then you can think about the chronic bronchitis, whooping cough. Is another important thing that you have to think about if the patient has a paroxysmal cough. And nocturnal cough is mainly in the asthma, tropical eosinophilia, chronic bronchitis, congestive heart failure, and the case of aspiration. And the postural cough, as I told, that is might be a bronchiectasis or it might be a GRD. So GRD mainly it is more aggravated when the patient is on the lying position. Okay, so if the patient is lying down, then if there is a reflux is more common on that condition, the cough will get aggravated. So then coming to the sputum color, so that will also give you certain clues. So if it's a serous, frothy pink, then you have to think about the pulmonary edema. And if it is a mucopurulent, it can be a bronchial or pneumonic infection. And if it is purulent, then it is a bronchial or pneumonic infection that we are going to think about. And then if the blood is stained, so there's cancer, tuberculosis, bronchitis, and pulmonary edema. So I'm going to come with the detail of the causes of crisis on the coming slides. Okay. So these are the things that we are going to think. So what are the red flags in case of patient with a cough? So it is mainly if the patient has hemoptysis, patient has increased shortness of breath, if the patient has a weight loss, fever, chest pain, and dyspnea, and dysphagia. Okay, so these are the important red flags when the patient will have a history of cough. So these are the red flags that we have to think about, and then we have to evaluate. Okay, and then the common triggers of the cough, like dyspeptic symptom, that is mainly in case of GRD, post nasal drip. So always ask about the post nasal drip or sinus problem, or whether there's a rhinitis or not, or and then the asthma. Okay, so these all are going to trigger. So these are the common triggers of the cough. And also now there's a sleep apnea syndrome. Okay, so sleep apnea syndrome is also going to trigger the cough. And then the medication associated with cough, like ACE inhibitors, calcium channel blockers, even is also going to cause, in some cases, fentanyl as IV bolus, topiramate, which is going to be used in case of migraine, phantoin, and sitagliptin. Okay, so antidiabetic. So these also are associated with some.
सर पोस्ट नेजल ड्रिप भनेको के हो?
Huh?
पोस्ट नेजल ड्रिप भनेको के हो?
पोस्ट नेजल भनेको तिम्रो चाहिँ अगाडिबाट सेक्रेसन आएन भने पछाडि घाँटीमा जान्छ नि भयो होइन. सो द्याट इज नोन एज अ पोस्ट नेजल होइन. नामै छ नि त पोस्ट नेजल होइन. अगाडि नाकबाट अगाडि ननिस्केर इफ इट इज गोइङ टु ब्याक अफ यर थ्रोट, द सेक्रेसन पोस्टेरियर न्यारिस छ नि त होइन, यहाँ मात्रै कनेक्सन हुँदैन नि त, पछाडि पनि त हुन्छ नि होइन, नोजमा होइन, थ्रोटमा कनेक्सन हुँदैन पोस्टेरियर नेजल. त्यो त्यो चाहिँ तिम्रो चाहिँ त्यो सेक्रेसन पछाडि गयो भने द्याट इज नोन एज अ पोस्ट नेजल ड्रिप. You got it? Huh?
यस सर.
थाहा पाइयो त होइन. सो त्यो भयो भने चाहिँ द्याट्स द पोस्ट नेजल ड्रिप होइन होइन. अनि फेरिटोन एन्ड सिटाग्लिप्टिन. सो दिज आर द थिङ्स द्याट वी आर गोइङ टु थिङ्क अबाउट. Then coming to the differential of hemoptysis. So if the patient has a hemoptysis, then we have to think about certain conditions. So you can always divide the causes into according to the system or according to this. Okay, so infective, neoplastic, vascular, autoimmune, and also. So to tell the causes. So infective causes are mainly if the patient is coughing out the blood. So then we have to think about, in the case of pneumonia also you can get hemoptysis. In case of bronchiectasis, lung infection and lung abscess and tuberculosis, or non-tuberculosis mycobacterium, that is known as a mycobacterium other than tuberculosis, that is known as mort. Okay, so mort. So the other organisms like mycobacterium cancer, apium complex. Okay, so all these are the things that you have to think about if the patient comes with a infective with a sputum production, which is mainly with hemoptysis. Okay, so this is comes tuberculosis comes in number one in our condition, in our context. Okay, so otherwise the other things that you have to think about is a bronchiectasis is also common in our scenario, because a lot of patient we are going to get is a post-tubercular bronchiectasis. Okay, so that is the sequelae of tuberculosis. Okay, so as a sequelae we are going to get the bronchiectasis in case of post-TB. Okay, so there are a lot of patient of bronchiectasis you are going to see in your clinical practice. And then coming to the neoplastic is a primary lung cancer, and then the lung metastasis, a bronchial adenoma, and then the vascular is uh, vascular is a pulmonary embolism. Okay, so pulmonary embolism is very common now because of the COVID. So a lot of patient of the COVID, we are getting a patient with the pulmonary embolism. So this is the one of the condition where we are losing a lot of patient with because of the pulmonary embolism. Okay, so there's might be a microthrombi or big thrombi embolus we are getting in case of COVID. And so now the pulmonary embolism is very common, and the pulmonary arteriovenous malformation. And then the autoimmune is a systemic lupus erythematosus, SLE, and good pastors. So there's a patient with a vagus. Okay, so the one patient who is recently been diagnosed of vagus. That is now the vagus is we are not going to say that as a vagus. We are going to say it as a GPA. So that's the granulomatous with polyangiitis. So the patient actually present with hemoptysis, with a fever. Okay, with just like a COVID-like features in the CT scan, but the PCR was negative. But our antibody against COVID was very high. It is on the 4,000s. Okay, and ultimately the patient landed into the cytokine storm. So we use all the modalities like methylprednisolone along with the cyclophosphamide, all these things, and we are able to save this patient. And ultimately the last diagnosis was also made on the GPA. Okay, so it's mainly associated vasculitis. So that has been aggravated because of the COVID on this patient. And patient also have a diffuse alveolar hemorrhage. hemorrhage on this. Okay, so diffuse DH is the another one that we have to think about, the autoimmune conditions in which the patient will have a hemoptysis. And then the other is the drug related, and the others always, if the patient is any bleeding from any side, always ask about whether the patient is taking anticoagulants, antiplatelets, or iatrogenic cause. It can be there, or it can be a lung contusion, or it can be a penetrating injury. Okay, so if there is a chest injury, then also the patient can have a hemoptysis. So completing the list of the hemoptysis. Then coming to the assessment of the severity of cough, we can use the certain scales like PAS score, or a cough questionnaire such as Lister cough questionnaire. Okay, all these questionnaires can be used for the assessment of the severity of cough, and this can also used to track the patient's response to the therapy, so that we can use that. So coming to the personal history, then the smoking is very important. The smoking history in case of chronic bronchitis and the lung cancer, or in case of COPD. Then history of drug allergy or allergy to known substance. Okay, so these are the important things that you have to take in the personal history. And family history, history of atopy, asthma in the family, so that also give you the clue. And the history of pulmonary tuberculosis in the family, so we can use that as a contact history to see whether the patient will have a developed tuberculosis or not. Okay, so these are the important family history. So now coming to the clinical examination in the respiratory system. So this is the figure which is given in a second page of your Davidson in the respiratory system. Okay, so you have to open up this. Otherwise, you will not able to correlate anything that is taken in the lecture. Okay, so lecture, because we are going for the clinical features and the signs. Okay, so those who are posted in the medicine, they will know it definitely, because in the 2 weeks time they will already been taught about this inspection, palpation, percussion, auscultation, all these things. Okay, so they will be easy for that. So those who are not posted in the medicine, so those who are posted in gynecology might find it difficult. So even in the pediatrics they can know it. Okay, so it's better you should go through with this figure. Okay, so whenever you examine the patient, we are going to examine with the hands, all these things, in which we are going to look for certain signs like clubbing, cyanosis, all these things. Okay, so in the hands, that is important. So there is a certain conditions which causes the clubbing, like bronchiectasis, lung abscess, lung cancer, all these causes the clubbing. So that will come in detail in the clinical practice. Okay, in the clinical classes. And in the lectures you will be told on that, so you should know about that. Okay, so what is clubbing and all those things. So clubbing will be there. Cyanosis, we can look on the hand, so it's mainly a pulse has also certain indication on the respiratory, like if it is mainly a high volumic pulse, then we have to think about certain conditions. Okay, the patient has the irregular pulse, then we have to think about the atrial fibrillation. And the blood pressure, that we are going to look with the paradoxal atrial paradox. Okay, so that's mainly important in case of severe asthma, in which if you take the blood pressure in the systolic blood pressure during inspiration and expiration, if the difference is more than 10, then in the inspiration, if the systolic blood pressure is difference is more than 10, then you can think about the atrial paradox is present. So it is mainly present in case of severe asthma. And then JVP, okay, so jugular venous pulse, that is mainly elevated in case of right heart failure. The right heart failure is mainly because of the pulmonary disease, that is also known as a or right ventricular hypertrophy or failure, because of the cor pulmonale, that is known as a cor pulmonale. So we'll discuss each and everything in the, one by in the coming lectures. Okay, and then in the mouth face examination, you can think about the port sleep, and cyanosis is there or not, bruised discoloration of the mucosa. Okay, and anemia, Horner syndrome, that you might have read in the applied anatomy. Okay, in the case of CA lung, because of the involvement of sympathetic chain, there will be a Horner syndrome. Okay, and then the inspection, there are certain things that you are going to look is the deformities, scars is present or not, introing, whether the both side of the chest is symmetrical or not, whether it's hyperinflated or not in the inspection, that you are going to look. And the palpation from the front, you are going to look for the trachea position. Okay, so trachea is central or not. If it is deviated to certain side, that might be a certain thing that you have to think about. If it is opposite, push towards the opposite side. Okay, so there is something lesion on the right, and the trachea you are finding on the left. Okay, so trachea is shifted towards the left, then there is something is pushing from this side from this side to left. Okay, so that might be a effusion. There might be a pneumothorax which is pushing the trachea towards the opposite side. If trachea is towards the same side, that it might be because of the fibrosis, or it might be because of the collapse. All these are the important things that you are going to look. Is a cricosternal distance that will give us certain things. Okay, expansion, cervical lymphadenopathy. All these are the things that you are going to look. And percussion, whether it's a dull or resonant. The dullness will give mainly in the effusion, or in conditions like consolidation, or it might be a resonant in case of hyperresonant in case of pneumothorax. And auscultation, breath sound. What are the types of breath sound? What are the added sounds like wheeze, crackles, robs? Okay, so wheeze is mainly because of the obstruction of the airways. So when there is an obstruction of the airways, just like if you are thinking about the के बाँसुरी सम्झ होइन बाँसुरीमा तिमीले प्वाल बन्द गरेपछि के हुन्छ इट विल प्रोड्युस सर्टेन साउन्ड्स ओके सो just think about the airways is just like a same thing. So whenever there is an obstruction, it will produce the certain sounds. Okay, so that's known as a wheezing. So it's mainly a visual sound. So crackles is mainly if there is something inside the alveoli. So alveoli, if there is a fluid inside, just like a bubbling water. Okay, पानी उम्लेको जुन किटलमा पानी उम्लेको जुन आवाज सुन्छौ, that's the similar type of sounds that we are going to hear while we are auscultating is known as a crackles. Okay, and rubs is just like if you rub two leathery things, just like shoes or anything. So that's a crickling sound. Okay, so creaky sound, that is a rub. So these are the added sound. So these are mainly present in the airway disease. So if it's obstruction, crackles is there is a secretion on the is. So to rejoin gara, so time sucking last. And then so these are the important things that you have to think about. And then the spoken voice like vocal resonance, whispering, pectoralici, all these things, and the legedema. Okay, so these are so you can go through this picture in your Davidson. Okay, and that will give you a good clue. And so that's also a mock for you. And so read the first 2 or 3 pages, okay, of the Davidson in the respiratory. So coming to the general examination, you are going to look for the clogging. So there's mainly interstitial lung disease and lung cancer, and then in the cyanosis, chronic bronchitis, palpable lymph nodes is there or not in case of lung cancer, and the pedal edema. So that you can go for to look for whether the patient has a congestive heart failure or not. Okay, so these are the important things that you are going to look. And then coming to the examination of nose and nasal cavity. So mainly nasal polyps or nasal discharge is there now or not. So that will give you the clue whether the patient is having a post-nasal drip or not. And then examination of throat, posterior pharyngeal wall, congestion is there or not, that you are going to look in the upper airways. And so chest examination, as I told, so is mainly a barrel shaped or not. So normal is epileptical, so elliptical shape. So barrel shaped chest in emphysema. So unilateral restrictive chest movement in empyema. So bilateral restrictive chest movement in emphysema, interstitial lung disease. Okay, so all these are the things that you are going to find. So on chest examination, trachea shift towards the